The mini grant is up to $3,500. We have a health literacy grant, which we had the steering committee, because of looking at the different grant proposals that we've received, have decided that we will refocus that grant slightly, so that in addition to health literacy, you can also apply for up to $10,000 for a grant to address social determinants of health. A lot of the grant proposals we're getting have been really dealing with issues like food insecurity, housing insecurity, transportation needs, linguistic barriers, low-income folks. So we really thought it would make sense, as a steering committee, we thought it would make sense to refocus that grant. It's a little bit clearer and a little bit, maybe just for us as a steering committee, as we're looking at the grants, to redirect the focus of that grant. So if you go on our website, which I'm going to talk a little bit more about at the end of the meeting, you'll see that those grants have all been updated. We go on a four times a year cycle. So the next due date for the grant, the mini grant and the health literacy social determinants of health grant, will be October 15th. So please take a look at our website. Kim has just put the website in the chat. Thank you, Kim. It's CHNA23.org, and /funding talks about the grants and has all the new updated documents. We also have a behavioral health grant, which I'm also going to talk about a little bit after our presentations. And the deadline, or the submission date for that, is also on October 15th. But we also, when we reinvest those resources into the community, we ask people to come back and tell us how they've done and how they're, what they've done with the funding and what impact it's had. So today we have a report from Tom Comiskey, who is the outreach librarian at the Plymouth Public Library. And Tom got a health literacy grant about a year, I guess more than a year ago. And he's come back to tell us what kind of impact it's had. So Tom, I'll turn it over to you. And I'm going to leave all the technical stuff to you and Kim to figure out how to share your screen. Thank you.
All right. Well, yes, this is the first time I'm sharing a screen, so be forewarned. Hopefully it'll go well. So first of all, I just want to say thank you to the South Shore Community Partners in Prevention for providing the library with this grant. My background in medical librarianship was my impetus in getting involved. So it was great that we could do this. So I'm just going to run through some of the highlights and see if I can share my screen properly. Host disabled participants share screening. Okay. Can anyone hear me?
Try now, Tom. Try now, Tom.
Okay.
Sorry. That's
all
my
right.
fault.
Let's see. Is that working? Let's see. Okay.
I'm just seeing it in front of you on your screen. We don't see it on ours just yet. Does it open up on your end?
It is.
Okay.
Should I reload it?
I would try it one more time. Yeah, it's not showing up, at least not for me.
No, me neither.
Okay.
No, me neither.
Share. Okay.
There we go.
That. Okay.
Perfect.
If it once you don't succeed, try again.
That's
okay.
right. Absolutely.
All right. So as I said, we started in March. We started rolling out programming, and a little overly ambitious. Can everyone see this? Yes.
Good, Tom. We can see it.
Okay, so a little overly ambitious. We we rolled out throughout the year 21 educational programs or events. And those included classes on learning how to use consumer health databases, websites. They included all kinds of fun programs for different age groups. We had the melanoma screening at the library. A total of 313 people attended all of the events and programs. So we had, throughout the year, was establishing partnerships and relationships with community providers, which I feel was the most exciting thing that we did for this program. And it really not only provided the library as a place to house a collection, but also present the library as a trusted partner to social service agencies, to other community agencies, and as well as the public in general, seeing a kind of a different side to the library, that we are a trusted source to for people to come and ask questions regarding health and health information. And then we had kind of our exciting event in September, which was the Community Health Fair, which we had about 17 providers outside on the front lawn. We had about 125 people attending that event, which was great. We had a lot of interaction. The providers said that it was a great opportunity for them to get to know each other, to get to know what each other does, sharing resources, etc. So unfortunately, we couldn't do that again this year. But I would love to do it again next year when we can freely be outside and move about the country. So the next thing that we focused on was taking the project out on the road. And what we pioneered was something called the Health Infomobile. And that we did get to launch back in February at Harbor Health. So it's a mobile little kiosk that gets set up in the lobby of a place. We chose Harbor Health. That's our first. We were targeting, hopefully, to have it as well as BID, Plymouth, and a few other spots in the community. So that's something we hope to do next year. So, and finally, the Consumer Health Resource Center. So this is a special little section in the reference area of the library. And we have over 200 books and materials. And we tracked over 25 consumer health reference interactions at the reference desk. So we had the opportunity to make people aware if they came with specific questions related to health or mental health, and we were able to keep track of that. We also had through the other grant we received from the National Library of Medicine, we had Chromebooks available so that folks can go and use those in the library to research their health concern. So I just want to share some photos of what went on throughout the year. This was making connections, building relationships at the health fair. As you can see, we had the influenza flu shots available, the melanoma screening, we had lung cancer screening. We had a host of different presenters. We had free coffee provided by Jolly Bean, so that was great. A few more pictures. NAMI was there, and it was a great day. It really was a great, beautiful day. Here's a picture of the Consumer Health Resource Center located in the reference area. We've continued to label that and keep it filled with current publications from the NIH, National Library of Medicine, free brochures, pamphlets, We're even extending, we have a few things that are in Brazilian Portuguese, as well as resources and flyers from different programs. So it's getting more use. We're getting the word out there. And then finally, this is a look at the Health Infomobile, which we set up. It's a collapsible stand that contains literature. As you can see, the Chromebook is there, and it was sitting right in the lobby of Harbor Health. Unfortunately, it was a very slow day at Harbor Health, so I only had 1 or 2 interactions within the 2 hours visit. But we hope, as I said, we hope to continue this next year. And so that's just a viewpoint of what we were doing. Any questions?
Yeah, folks, if you want to unmute yourself, you can ask a question. I would just say, especially the health fair was a beautiful day, and having it right in the front lawn, a library where people are coming in and out anyway, and on that main street where people, you know, if you remember in the days before COVID, on a beautiful day in the fall, if you're driving by and you see tents or a table set up, you know something good's going on and you want to check it out. So we really lucked out with the weather that day, and I think we had a lot of people come by who maybe weren't even aware that the health fair was happening, but they were able to get some good information. So does anyone have any questions?
Hi, yes, Tom, this is Heather from Pembroke Hospital. We attended the community health fair, which was really awesome to get everybody in one space to help the passersby kind of have that full effect with all the providers. But I just had a question about the resources. Are you interested in getting like more resources together from different agencies, or do you kind of have what you're looking for, or is there kind of a, you know, standard that you're looking for, or anything like that?
No, what I ask is if anyone has a book, a CD, you know, whatever kind of resource, send me some information about it in an email, and then I definitely would welcome adding resources to the library. So yeah, definitely.
Thank you.
Tom, maybe you can put your
That would be
email
great.
in the chat. So if folks want to get in touch with you about resources,
Sure.
they can contact you directly.
Absolutely.
There it
Yep.
is. Great.
I
Thanks,
can,
Tom.
yeah, while we're not open to the public right now, I do have email access, phone access, etc. So.
Okay. Tom, you're breaking up a little bit, but I want to thank you. And we do look forward to the
Any other
days when we
questions?
can get the Health Infomobile out there and get folks back into the library and using that Consumer Health Resource Center. So I want to also thank Tom. Tom is one of our very active members of our health literacy subcommittee. And for folks who are new, we should definitely make note that health literacy is one of our strong initiatives as part of the South Shore Community Partners in Prevention. We adopted it about 3 or 4 years ago and decided to devote a lot of our resources and time and effort to improving health literacy, because we believe that improving health literacy improves health outcomes for folks in our region. So if you're interested in health literacy efforts, in improving health literacy and finding out more about health literacy, definitely be in touch with either Kim or myself. And also, she's not here today, but Bethany Bergen, who is our health literacy coordinator, is doing a great job, works with the subcommittee, and she's raring to go. She wants to do a virtual health fair. So I guess we'll hear more about that over the next couple months, but stay tuned for that. So Thank you, Tom. So at this point, I am going to introduce our two speakers. I guess I'll start with the first speaker, and we're very happy and delighted to have Karen Keane here today. She is the director of the Plymouth Public Health Department, and she's going to talk a little bit about the contact tracing program. Obviously, the pandemic is the #1 health issue that we're all dealing with, I think, no matter what our individual focuses are. So Karen, thank you so much for being here, and I'll turn it over to you. You might be on mute, you might need, oh, you're unmuted. So Karen, go ahead.
Okay. Thanks so much, and thanks for having me here today. A little bit of an overview of what's happening in Plymouth currently as far as COVID and the pandemic. We currently have 660 confirmed cases since the beginning of the pandemic here in Plymouth, of which unfortunately we've had 75 deaths. The deaths have come mostly from people in the elderly range of 70 and above, and they had multiple other health conditions besides COVID. And most of them came from our congregate settings, which is our long-term care facilities. That's the dynamic of who is being tested and confirmed positive for the town of Plymouth is changing, and it's changing rapidly. When the virus first hit our town, it was mostly the congregate settings, the long-term care facilities, the rehab facilities, people in the hospital. What's happening now is our numbers are changing to reflect more of 20-year-olds and 30-year-olds, and even younger, some teenagers. No one's school age as of yet, but we will be keeping a close watch on that as we get closer to the opening of school, and when school does indeed open, even remotely, you know, in the hybrid format that we're following here in Plymouth, we'll be keeping a close eye on that. But what's happening, interesting enough, with the change in age group is a lack of cooperation with contact tracing. It's very important when you are diagnosed with any contagious disease, and I try to explain this to people when I talk to them on the phone. It's not, we're not singling anyone out because they have coronavirus. Any contagious disease that a person is diagnosed with in the town of Plymouth, I know about as the director of public health. It comes through a database called the MAVEN database system, and I am told from the lab tells the state of Massachusetts tells me, and it's by where you live. So if you lived in Rockland, the Rockland Public Health Department would get that information. If you lived in Millbury, the Millbury Public Health Department would get the information. I get information for people who live in Plymouth. So once I receive that information, I work with a company called the Contact Tracing Collaborative, or CTC, which is a group from Partners in Health, not Partners Healthcare, it's a different company, it's called Partners in Health, that has worked with the state of Massachusetts to go and do contact tracing. What that means is they will call the person who is being diagnosed with coronavirus. Let's say it's Karen Keane. They will call Karen Keane and they will ask me who I have been in close contact with. Close contact by definition means this. Who have I been closer to 6 feet for longer than 15 minutes? So it's not someone I passed in the hallway. It's not someone I saw at Stop and Shop and talked to for a few minutes. It's who have I been closer to 6 feet to for more than 15 minutes. That's important to know because that's how the virus is spread. So we need to know who those contacts are. What's happening with this newer group of people, the younger group, the 20s and the 30s, is they're very reluctant to give that information. Our older population was not reluctant. They would tell us who they were in contact with, who lived in their households, if they still worked, who were they working, who were they close to at their place of employment. But we're finding a little bit of reluctance on the part of the younger folks. And that's a challenge that we're facing currently, because it's really important still that we know who these contacts are, because we want to stop a super spread. Example would be, we have a church in Plymouth that had a small cluster of people test positive for COVID, and then they went out to their places of employment. So now we have additional cases at places of employment that can be traced back to what happened at that church. So that is starting a super spread, meaning it's not just in one location anymore, it's spreading out to multiple locations. It's so important that when either I call or the people from the contact tracing collaborative call, that we can gather that information. It's still kept confidential. It's still only between myself, the person I'm talking to, and the people that I'll be talking to from their contact tracing, because it's so important that we gather that information in order to stop the spread. That's the whole purpose of it. We're not being nosy. We're not trying to, get into anyone's business. We need to know this so we can know where the potential is that this virus could also keep spreading, because we want it to stop. So that's what contact tracing really does. It takes the person, the case, we call the person the case. The person who has coronavirus, they are the case. We need to know who that case came in contact with in order so that we can put a control on the spread. And that's where contact tracing comes into play. And that's why it's so important. If you get that phone call and it says, contact tracing or tracing collaborative or town of Plymouth, it's important to answer that so that we can gather that information in order to stop the virus.
Great, thank you, Karen. A follow-up question. So once, Karen Keane gets called and she says, oh, I was with Susie Smith for dinner the other night, whatever. What does Partners in Health or the caller, what do they do with that information? Do they contact Susie Smith then?
Right, so what will happen is inside the database of the Maven database will be added the close contacts. So you'll see my name as the case, and then they'll be listed, it'll be attached to me, my close contacts. It would be people in my family, not so much people I work with because we're so socially distanced here, but it would be, say, the people that I live with. So then the contact tracing would say, okay, well, let's talk about the people that you live with. They'll need to either be tested or quarantined for the 14 days to make sure that they're not active with the virus. Who else do you have? Oh, well, you know what? I did go to a birthday party, and these are the people that were at that birthday party. I wasn't really close to them, but you know what? Maybe I was. Oh, you know what? I shared a ride with, Auntie Sue, so we better contact Auntie Sue. So then we'll contact Auntie Sue. We don't go to the contact of a contact. We don't go that far down, meaning Auntie Sue might say, oh, well, you know what? I played bridge with, 3 of my best buds, but we're not going to go that far because right now we don't even know if Auntie Sue is a positive. We're looking for the case who's positive and their immediate contacts. And that's who we placed into the Maven database because they need to quarantine.
And are folks who are those contacts who have the follow-up calls, are they offered testing or are they given information about the Stop the Spread initiative?
Absolutely. Absolutely. They're giving so much information. They're given resource information if they need anything like food or medicine delivered while they're quarantining. Do they need any kind of social support? You know what I mean? Anything that they need, there's resources that are available to those folks so that they can stay in their homes while they need to quarantine, but they can still have all their needs met.
And does Partners in Health or the Contact Tracing Collaborative have any estimates or any data on how many people are actually complying with that quarantine, or do they have a guess?
Well, when it started, we were averaging about 2.5 contacts per person. At first, everyone thought it was going to be a much larger number. Everyone was anticipating 10 or 12. It really isn't like that when you come down to the definition of what a close contact is. So the people were averaging about 2.5. What we're dealing with now is we're having people not even telling us. So that's the difference. You know what I mean? When we were finding out the information, it was good, and it was 2.5, and we knew who it was. We're having a little bit of reluctance. That's why I would encourage everyone to give that information to the people that call, because it's so important that we have that. And
I would just say, sorry, go ahead.
More than once. Do you know what I mean? They won't just try and give up. I mean, we try, and we're in constant communication with each other. So yesterday I heard from contact tracing, they were having some difficulty reaching a couple of people. So they asked me for my assistance. So I'll help them out. Or if I'm having trouble reaching somebody, we're in constant communication with each other to really make sure that we gather as much information as possible.
Great. And as I'm asking follow-ups, if people have follow-up questions they want to put in the chat or raise their hand, I do have everyone on mute just so everyone can hear the main speakers. But so if you have a question, please do put it in the chat. I guess my last question I can think of right now, can you talk a little bit about the potential scam calls? I know I've heard that there have been some scam callers always taking advantage, as they do, of this, who call and say that they're from the contacting tracing, whatever, collaborative. I'm sure they don't use the right word, but how can someone tell that the call they're getting is a legitimate contact tracing call?
Okay, so there's a couple of, and I don't know them off the top of my head, but there are several phone numbers that are listed on mass.gov that these phone calls will be coming from. So if a person has caller ID, they'll be able to recognize that that's what those phone numbers are. The other thing is I'm never going to ask, and contact tracers never going to ask any type of personal information such as your social security number, anything like that. So if someone starts off by saying, let's start with your social security number, disconnect that phone call. You already know that that's not coming from a reliable source, because we're not going to need that information.
Right, and I heard one of the reports I heard said that the scammer will also ask for your credit card number and say, oh, in case we need to charge you for the test or whatever.
Right,
So,
we're never going to ask that information.
Right,
like
that's important. Do have a question from Amy Sylvia. Is the name of the case kept confidential? So when, Karen Keane's the case and we're calling Aunt Susie because she was at the birthday party, do we tell Aunt Susie that, hey, you were with Karen Keane, or do they just say you were with someone who's been tested positive?
We will let them know that they have been named as a close contact of someone who has tested positive.
But not name the person?
Correct.
Okay, great. All right, excellent. I don't see any other questions. If folks have questions, you can certainly put them in the chat, and maybe we can just see. Oh, here's a few questions. Thais, who I also was on the 8 o'clock call, Thais from Harbor Health. Hello, Thais. Question about the homeless population. We have heard of people who are experiencing homelessness and tested positive. How has the department navigated that?
I have not heard of anyone tested positive from the homeless population.
Okay. And if someone wanted to, and that information you would be getting would be through Maven or Marvin, right?
Right.
Yeah.
Database.
Okay. All right, great. And Tom is just saying from the library, if you have a helpful graphic for contact tracing for a Facebook post, please let us know. The library would be happy to post something on their Facebook page.
Thank you.
So, and Tom's information's in the chat. So.
Yeah, I wrote that down.
Well, Karen, thank you so much. We really appreciate your being here and sharing that information. I think a lot of people do have questions about this because, you hear about it in the governor's press conference and maybe a news story, but it's for someone who's actually doing it and getting that feedback, it's really important.
And for the most part, I mean, I always tell people, it's always come back to the basics. It's the basic big three, social distance, wear your mask, and wash your hands. I mean, that hasn't changed. Those are the big three, and those are the three things you can do to protect yourself and to protect others. And those still remain, and that's the message we try to get out as much as we possibly can.
And I guess I would just since you mentioned Mass, and I know Plymouth has an ordinance, can you talk a little bit about how that's going?
Sure. The process is if a person it's complaint driven. So either we receive a complaint from the state Department of Labor Standards might get a complaint, the governor's office might get a complaint, we might get a complaint here through our office, and then we send out and we investigate. So we go to the location where the complaint comes from. It may be about staff not wearing a mask. It may be the store is too crowded. It may be the restaurant has tables that are way too close together. And then we go out and we investigate. And the majority of times, it's just an educational process. We go out there, we see what the person had been complaining about. We talk to either the owner or the manager about what the complaint was and what needs to be done in order to fix that. I have to say that every business has been amazing in the town of Plymouth when it comes to really making the changes that are necessary in order to stay safe for our residents and our visitors. So when these people have a little stumble, you know, when these businesses or establishments have a little stumble, it's really just a matter of education. And then we educate them, and then we use some additional literature with them, perhaps some additional signage they can put on their front door, signage they can put inside their establishments, so that people are aware of what has to happen. Then if the complaint came through the state or through any department within the state, we follow up with that department to let them know what we did and what we did for education and what we're going to do for a follow-up. There's another question. It says, can anyone get a test yet? Yes, there are some locations that will now accept anyone, even though they do not have any symptoms. You do not have to be symptomatic. You do not have to have a referral from your doctor. One place that I know of is Convenient MD, which is located exit 12 in Pembroke. I think that's the closest to us right now that's doing that without a referral, without any symptoms. What about gyms? Okay, so gyms are a little interesting. You have to wear a mask in the gym unless you are 12 feet away, not 6 feet, unless you are 12 feet away from the person next to you. Something very interesting came up with one of our gyms here in Plymouth. As you might or might not know, the governor's order for wearing a mask does have an exemption if you have a health condition. That means you do not have to wear one, and people cannot ask you what the health condition is. If they say I have a health condition, you cannot force them to wear a mask. One of our gyms said, well, we don't want them to come in. We want to say we are masks only, and if you cannot wear a mask, you cannot utilize our services. So that was brought all the way to the state for a review. And they talked to this particular gym's corporate office, and it was determined that a privately owned business has the right to say that they are strictly masks only, and that they have the right not to let a person who is not wearing a mask for whatever reason come into their establishment. They can still offer them the services if they can remotely, curbside, or in the case of the gym, they were willing to freeze that person's membership or cancel the membership without penalty. Let's see, my son had a test so he could travel to Maine. Okay, no charge, the results came back in 2 days. Oh, okay, so that's good, so it did work. So they went to Convenient MD and it worked exactly the way that it should, so that's good to know.
And also, I would mention the Stop the Spread initiative through the state. There are several cities, hotspots, if you will, that have multiple testing sites. I think Brockton is probably the closest one to us in Plymouth.
Yeah, Randolph has done a couple, and anytime that they do one, we post it on our social media so that folks know, because it is open to anyone in the state can go. It doesn't have to be from that municipality. Anyone from the state is welcome to take advantage of that.
Right, exactly. You don't have to live in that town or city to go there. So, and you can find that information on the state website as well, the Stop the Spread Initiative. Well, Karen, thank you so much. I really appreciate your time. We're going to have you back now to give us updates on what's going on.
Absolutely.
Because I think you're a great resource, and we really appreciate you being here.
Right.
So I'm going to introduce our second speaker now, and that is one of our board members, one of our steering committee members. Siobhan McKay is a nurse with the Department of Developmental Services, and she is going to give a little bit more of an overview of the different types of tests, because I think people do have a lot of questions about the nasal swab versus the cell test versus the antigen and the antibody test. So Siobhan, thank you so much for, I know you do these trainings for your fellow employees at DDS, and we're happy that you were able to modify it a little bit for our needs. So I'll turn it over to Siobhan.
All right, let me just put this on.
Siobhan, we don't even get to see you. We're just going right into the share the screen, I guess.
Yep. Okay, can everyone see this?
Yep.
Okay.
Yeah, it's on screen. Yep, thank you.
So I just have a couple of slides on what is COVID-19. I'm sure everybody knows. Recently identified novel coronavirus. There are, the symptoms can have a huge range from mild to no symptoms to severe illness, and they can appear anywhere from 2 to 14 days following the exposure. It's primarily spread by respiratory droplets, and like Karen said, individuals can be infected by coming into close contact with somebody. There are times when it is airborne, but it is primarily respiratory droplets. So, and because it's novel and new, everyone's potentially at risk for getting COVID-19. So there are currently no approved treatments or vaccines, but we're working on both of those. And there are some treatments that have shown good promise. So we're working on it. So COVID-19 symptoms, this is according to the CDC, and this can change as we learn more about it, because again, it's only been around for about 9 months. So fever seems to be the most predominant, cough, fatigue, anorexia, shortness of breath, sputum production, fatigue, also loss of taste and smell. That is kind of one of the newer, bigger ones that we're now figuring out. We didn't know that at the very beginning. There's an incubation period, and the average incubation period is about 5.1 days. But estimates are that less of 2% of people will show symptoms within the first 2 days, but 97.5 will show them by the 12th day. And that's why that 14 days is so important, because we'll get most people, over 97.5% of people that will develop symptoms or become positive in that time period, if they will. So the CDC does recommend quarantining for 14 days following close contact with someone known or suspected to have COVID-19. And there is some information that's coming out on viral shedding and transmission. There's a couple of studies that have shown that infectiousness started 2.3 days before symptom onset and peaked at about a day before symptom onset, with infectiousness declining within 7 days. So that was something that we didn't know at the beginning, that there was this, substantial pre-symptomatic or asymptomatic transmission, which is why the contact tracing is so key, because we need to get those people that may not have, you always assume that, oh, I was around somebody who was sick, who was showing symptoms, that's where I got it. But there is quite a significant amount of asymptomatic or pre-symptomatic transmission with this. And I'll talk about it in the testing piece that, you can test positive for many weeks, but just because you're testing positive 6 weeks after your initial positive doesn't necessarily mean that you're able to transmit the virus at that time. So that can be confusing for a lot of people. So again, preventing the spread, stay home if you're sick, avoid large gatherings and lingering in high traffic areas. A lot of waiting rooms have closed, and now we're waiting in our cars for appointments, getting calls to go in, wearing a cloth face covering over your nose and mouth when you're out in public, practicing good hand washing. If you have access to sink and soap, that's what you need to use. If you don't, hand sanitizer is a very good secondary option. Cleaning and disinfecting frequently touched surfaces is huge as well. So there are pretty much basically 3 types of testing that's available right now. There's the molecular testing. That is most of the testing that's available is molecular. It's your reverse transcriptase, polymerase chain reaction, LAMP, RPA, CRISPR testing. Then there's also antigen testing, and that's the rapid antigen test. Those are the ones that are coming back within the 15 minutes. So they are different from molecular tests. And then there's the serological testing. That is testing for antibodies. So even though there's 3 types of testing, there's 2 reasons for testing. There's a viral test, which will tell you if you have a current infection. Those are the molecular tests and the antigen tests. The antibody tests will tell you if you had an infection in the past. And those are not for diagnostic purposes. Those are for studies pretty much only. They're not as effective as other antibody tests because, again, this has only been around for 9 months. So testing is getting better. So as of September 2nd, there are at least 265 COVID-19 tests that are either EUA authorized or pending authorization in the United States. And nothing has been approved by the FDA because, again, approval takes rigorous time and lots of testing to be approved. But everything has been EUA authorized. It's an authorization, an emergency use authorization. I apologize, I have to plug in my computer. Okay. So of those 265 tests, 187 of them are PCR tests. So that, again, PCR, that's the gold standard of the test. So most of the tests that you're going to be getting are PCR tests. 6 are isothermal amplification tests. Those are really good for point of care testing because you don't have to worry about temperature. So those are the really good ones that are able to be done, say, in a doctor's office. 4 are sequencing tests. 3 are at-home collection test kits. Those are rapidly expanding now because it's an option that people want to use. A lot of schools are using them. A lot of colleges are using them. 3 of them are CRISPR, which is a really new technology, which I'm very excited about. So I'm glad to see that there's a bunch of those available. 5 are antigen tests. So that was that other type of testing that can tell you if you have an active infection. And again, the antigen tests are the rapid ones. They come back in 15 minutes. 55 of them are serological, which is the testing for the antibodies. So let's see. Molecular tests. Those are the PCR, the isothermics, the LAMPs, the CRISPRs. Those are used for diagnostic testing purposes. So they'll tell you, again, if you have an active infection or if you are still have the RNA in your body. So PCR is the gold standard. There are different ways to get this done. The nasopharyngeal swab, and I have to change that, it's not swab. The nasopharyngeal swab, that has to be done by a medical professional. So everyone's gowned up completely when they're doing this, and they put a long swab up your nose and kind of go back into your throat. That one has to be done by a medical professional because you don't want to cause damage. So that is using a lot of PPE because they have to change their PPE every time they're doing it. So there's been a lot of recent studies doing nasal swabs where you're just doing the nose, or oral swabs where you're just, swabbing the mouth. And those can be done by the patient under supervision. So that's saving PPE right off the bat. And those are just as good as the nasopharyngeal swab. So you're going to be seeing a lot more of just, doing the nose or swabbing the mouth. Same test, it's getting the same material, it's just getting it from a different area. And there have been studies that show that those are just as effective. So that is a good secondary option. Antigen testing. This is used for diagnostic purposes again, and it detects protein from the SARS-CoV, respiratory specimens. The results are typically within 15 minutes. Rapid antigen testing, the positive will result really quickly. It takes about 15 to 30 minutes to get that negative test. They're very specific for the virus, but they're not as sensitive as the previous ones, the molecular tests like the PCR. So if there's a low viral load, there's a chance of a false negative result. It's a much higher chance of false negatives with antigen. So this test is not recommended to be used if you're asymptomatic. So if you're asymptomatic, you're getting a molecular test, you're getting a PCR test. It's more sensitive, it's more specific, and having a negative on that means you don't have it. Having a negative on an antigen rapid test doesn't necessarily mean you don't have it. So there is something in the literature that says if you have a negative and you're symptomatic on an antigen test, it needs to be confirmed by a PCR. So they're good, but you have to take everything, you just have to be careful how you're getting that done. So the PCR tests, they can be done within 3 to 4 hours, but there are so many tests being done that it's very rare that it will result within 3 to 4 hours. So usually you're getting the test results back for a PCR within a day or two. There was a time that we were taking up to 8 to 10 days to get those results because there were a lot of tests being done. But now that more labs are getting on board and more labs are able to process the test results, it's taking less time for the results to come back. So they can come back pretty quickly, but typically within 2 days. Okay, so this is one of the antigen tests. It was one of the first antigen tests by Quidel Labs, and it was first given EUA authorization in March. Tests can be performed in both CLIA labs and at point of care settings that operate with a CLIA waiver. So that's why a lot of doctors' offices might have this, which is really good. Again, a positive result is highly accurate on a rapid antigen test, but a negative result does not rule out an infection. Negative results should be treated as presumptive and confirmed with a molecular test if necessary. And they might not be confirmed, that you might become what's considered a presumptive case, and then you're essentially told to quarantine. So if no additional tests are done, the CDC recommends that you should stay home until you've had no fever for at least 72 hours, and it's been at least 7 days since the symptoms started. And then serology tests. So this is the one that everyone wants because you want to know, am I immune now? Did I have it when I had that horrible cold back in February? So they detect IgM, IgA, IgG, or total antibodies. It is not a diagnostic test. These just aren't as sensitive as we would like because, again, it's only been around for 9 months. It's not useful for determining acute illness at all because development of antibodies take time. There are some antibodies that might come in 2 weeks. Some it takes a couple of weeks or a couple of months for them to develop. So this is for research and surveillance purposes only. And again, Massachusetts started putting people who had positive serology tests into the numbers, but then they separated them, which was a really good idea. I really liked that because I take those people who tested positive on serology with a big question mark because we don't know. They certainly might have been infected and now are immune to it, have the antibodies to it, but we don't know for sure because these tests are not very sensitive. So the majority of antibodies are produced against the NC protein, and tests that detect that NC protein would be the most sensitive. But many manufacturers don't tell you the nature of the antigens that they use, so you don't know what they're looking for. So you're not positive, is this the better test that I'm taking or is it not? So more to come on serology tests. But I do like that Massachusetts separated those two out. Now we have molecular tests. Again, gold standard, highly sensitive, highly specific. If you get a positive on that, yeah, you have it. Serology tests, not as sensitive, not as specific. If you have a positive, you might have had it, but we don't know. So sensitivity and specificity. Sensitivity is the percent of patients who have a condition that will test positive. That's a true positive. The higher the sensitivity, the lower the number of false negatives. The specificity is the percent of patients who do not have a condition that will test negative. The higher the specificity, the lower the number of false positives. So, and you have to take those with a pretest probability to interpret them. If you're in an area where there's a lot of people who are testing positive, your high pretest probability would make it very likely that that positive is a true positive, because the chances of them actually getting it, because it's so prevalent in the community, yeah, that's a true positive. If there's a low pretest probability, it could be that that positive is a false positive. And I don't know if anyone saw on the news yesterday and this morning, but there is a company out in the seaport that they're doing some testing, and they found out that they had 300 plus false positives. So again, nothing is FDA approved yet, they're all emergency use authorized. So you will see that some get that EUA and then they get it revoked. You'll see that some of the tests as we're going along might not be as good as some others. But again, we're in a pandemic, and the FDA has weighed that and said, okay, you've shown that you're doing a good job getting these tests done, and we need that. And as we get more into this pandemic and we're getting more and more studies and more tests, we're going to tighten those numbers and figure out which tests are the best. So far, molecular tests are really good. And that would be the one, if I'm going to get a test, I'm going to get a PCR test. So that's kind of it. I have a lot of resources and a lot of articles if anyone's interested in reading them. Everything, I will say, one of the really good things about the pandemic is that every single thing that's associated with COVID-19 has been made publicly available so that researchers can equally share their research, and there's equal open access to everything, because it's a global effort to get this thing under control.
Siobhan, that's awesome. Thank you so much. If folks have questions, they can definitely put it in the chat. I did have a question about that story that was in the Globe about that company in the seaport. I think it's called Origins.
Origin. I didn't want to say the wrong name. Thank you.
Yeah. So with so many false positives, A, how did they know? How did they figure out they were false positives? And B, do we know what kind of tests they were using?
I believe they were using an at-home test kit. I'm not exactly sure. I haven't read the whole article. But somebody mentioned it to me yesterday that this was coming. So
Yep.
I did see it on the news this morning. They do a lot of control testing as well. I think that one they weren't doing the proper controls.
Okay.
To figure out that, yes, these were true positives, or no, these were false positives. And that's, again, not every lab is equipped to do testing. So that's why it has been hard getting some labs up to date to get the testing done.
Right.
One of the ones that I'm really excited about is the Yale School of Public Health came out with a saliva test, and they open sourced it. So they're writing the protocol down and just giving it out to labs. It can be done with a bunch of different reagents that are commonly available in labs. So once that is up and running, it's really going to kind of explode testing, that any lab who has these reagents and has the ability to, take a swab can do a test now. And that's, the more testing we have, the better we can get this under control.
Yeah, and you mentioned the reagents. I just know through my office, we've had a lot of discussions with hospitals in the district who are doing testing, obviously, and need to test their employees as well as the patients who are coming in. And reagent, there was a long period of time when there was a shortage, and they couldn't do as many tests as they wanted to. So it's definitely been a difficult process.
And that's why it was really...
Go ahead.
Well, I was just going to say, that's why having, especially now when we're going into the fall with the flu season, there are some pool tests where you can get one swab to do tests for both influenza A, influenza B, and COVID, which is huge. But the ability to now do not just the nasopharyngeal, but to do the nasal swabs and to do the oral swabs is huge. It's going to protect our PPE. That's a lot of PPE that's being used
Yeah.
if you have to change between patients for a test. Because if our
Right.
testing is coming back at, thankfully, less than 1% of people who are tested are coming back positive, which is awesome. But that
Right.
means 100% of those people that are going for tests, if they're all being done with the nasopharyngeal swab, we're using all that PPE just for testing.
And do we have a sense of the nasopharyngeal swab and the self-tests, like the oral swab? Are they equally sensitive? Are they equally specific? Do we have a sense of that?
Yeah, there was a clinical trial that was going on specifically to see about preserving that PPE, because the nasopharyngeal swab requires a PPE,
Right.
but a nasal swab, you can put that on the counter, stand 6 feet away and watch the patient do it, or an oral swab as well, and you're not using PPE. So that particular clinical trial was to figure out, is that as sensitive, and can we move forward with that? And they found out, yes, it is as sensitive.
Great.
It's a monitored one, so the nurse or the doctor will watch the patient do it to make sure they're getting in the right area. But it preserves that PPE, and it's just as good. And again, it's not as uncomfortable. I mean, getting something up your nose and shoved into the back of your throat is not comfortable.
Right. And Charlotte Tarsi is saying that her daughter got the oral swab for her college used, and she did it over Zoom. So
Yeah.
so they're able
it's
to
great.
monitor it. Yeah.
And a lot of colleges are doing that, or the at-home testing kits that, they send them out to the students. Students do that, send it out, get it done at the lab. You get the results back in 3 days.
Yeah, so this is great information. Again, if folks have questions, you can throw them in the chat. We are recording this, so this presentation will be available. I think Kim is posting them, most of our meetings, on the website, and then maybe on our Facebook page too, I'm not sure, but it's definitely available. People want a copy of it. I have one last question, and far be it from me to get political, but you talked about how important it is, because if you're asymptomatic, but if you've been in contact with someone, it's important to know that. And as we know, there's been a lot of mixed messages from the federal government in terms of whether asymptomatic people should even be tested. So I don't know. I don't think I have a question other than thank you for putting that in there, because I think it's so important to bear that in mind.
It definitely is. And again, I mean, back in March, we didn't know how many people were asymptomatic with this, and that the Diamond Princess cruise ship was critical in figuring that out.
Right.
And figuring out that ventilation systems need to be up to snuff as well.
Right.
This has only been around for 9 months. What we knew 6 months ago, we now know so much different, so much more, and who knows what we're going to know in 6 months from now. It's just, it's very important. And it's unfortunate that some people are being refused testing if they're asymptomatic, or their insurance is not being run for it. I do hope that changes, because to me, absolutely asymptomatic. There's a lot of people out there who are asymptomatic, and we need to know it for contact tracing purposes.
Great. Well, Siobhan, thank you so much. There's a lot of great information. Getting a lot of thank yous in the chat for you sharing it and putting this together. And as I said, we will make it available to folks. So thank you. I have a few announcements to make, and then I'll open it up to everyone for announcements, and I'll unmute everyone at that time. But two things I want to mention. I mentioned the behavioral health grant before. We are offering it again for the third year, and that is a grant of up to $25,000 a year, renewable for up to 3 years, to have an impact on behavioral health. We had a great presentation last year by Sarah Cloud from BID Plymouth, and Kelly Maycomber, who is the Plymouth Youth Development Collaborative's coordinator about behavioral health, mental health, substance abuse, health issues are covered under this. And we are offering that grant again. As I mentioned, it is, the deadline is October 15th. The grant is available on that website that Kim shared, chna23.org/funding. And the real news is that we are having a bidders conference this year. Last year we had several applicants. We were really glad to see that, but folks did have questions about the RFP. So we want to have give people the chance to ask questions after they take a look at it and find out more about the RFP at the bidders conference, which will be next Thursday, September 17th at 4:30, and of course it will be virtual. We'll get that information out once we have the Zoom details. Our person who wrote the grant is actually hosting the conference, and she's going to run the Zoom. So once we get those details, we will share that with folks. But please do a save the date for September 17th if you're interested in that grant at all and possibly submitting an application. And as I said, you can look at the grant right now. It's available on our website. My other announcement is that, speaking of our website and speaking of health literacy, which I spoke of a while ago, we are again holding another Yeti giveaway. Nancy, hold up your Yeti. Look at that lovely Yeti branded with the South Shore Community Partners in Prevention logo. You can use it for hot drinks. You can use, oh, see, it's a Yeti. We're not kidding. It's spelled right. It's not a knockoff. You can use it for hot drinks, cold drinks. It's great. Oh, well, you bought the straw separately, but we won't mention that. But we are giving away a Yeti to some lucky person who goes on our website and looks at our glossary. We have a glossary of terms there to try to increase health literacy. I will say, Siobhan, you used a lot of new acronyms today, that some of which I wasn't entirely aware of, but we do have a glossary of terms and acronyms, and we'll have an announcement about the contest on our Facebook page. But because October is Health Literacy Month, if you go on our website and look at the glossary, and on our Facebook page, mention 3 items that you were not aware of, and maybe suggest 3 new acronyms or new terms that we should include in our glossary. So we're kind of working out the details. It'll all be in the announcement, which will be coming in the next few weeks. And yep, thank you, Kim. Kim just posted the Facebook page. And also,
Michael,
so everyone who enters.
I have to leave. I just wanted to say goodbye to everybody.
Okay.
I have to jump in another call.
Thank you so much.
Thank you.
All righty.
Bye-bye.
So yeah, we will draw from everyone who posts on the Facebook page the 3 glossary items that are new to them, and 3 that they think we should add to the glossary, 3 acronyms or terms. And everyone who posts will be entered into a hat, and we'll pull a name, and someone's going to get a free Yeti. So to keep an eye out for that. And again, it's a way to get folks to look at our Facebook page and folks to look at our website as well. So those are the only announcements I have. If people have announcements, I'm seeing in the chat. Jen Hoadley, Jen, are you still here? I don't know if she is. She posted that. Amy, you have an announcement. Okay, I'm gonna. Can you unmute yourself, or I can unmute you, Amy?
Yep.
Go ahead.
So I had an announcement to make. I've changed my position within the company. I'm still going to be attending the CHNA, but I'm now going to be working as the coordinator of domestic violence services for the center and for community-based services. But I wanted to introduce today Catherine Higgins. Give him a wave, Catherine. There you go. Who is going to take over my position as the program coordinator for the Impaired Driving Road to Healing program. So she's worked for our company for a while now in a different capacity in the courthouse. And she is going to, as of today, take over my baby. And I'm going to move to my new position. So I just wanted to let everyone know that she is now the contact person for that. And if you have any questions or concerns or need information about domestic violence in our community, you can give me a shout. That's it.
Awesome. Thanks, Amy. And Jen did have to leave us, but her announcement was that it's in the chat. All the Alzheimer's Association resources are available at that the link that she posted. Virtual programming can be found there. And she announced that the Walk to End Alzheimer's is happening. It is one of their biggest fundraisers of the year. They're doing it. People are doing it not as obviously as a big walk together, but people are doing it in their own neighborhoods. I've done the walk for several years myself, and I will be joining my team at a smaller gathering. I think it's last Saturday in September. So please do check that out. Does anyone else have announcements? Is anyone new who wants to introduce themselves? I know Amy introduced Catherine, so we're happy to meet you. Is it Matt? Meany? Mark, sorry. I knew it was an M, but I knew it wasn't my name. Go ahead, Mark.
Good morning. I'm Mark Meany. I'm filling in for my wife this morning, Kelly. She had an appointment. She's expecting in another 4.5 weeks, so things are getting pretty hectic around the house right now. My wife and I started Matthew's Gift within the last year. The purpose is we lost a son to stillbirth 2 years ago, Matthew, and we want to honor him and helping local hospitals, outpatient centers. When mothers receive this news, they're often not prepared for it, the decisions that they need to make going forward, getting the proper care, and also sharing that with your family. So with this grant that you gave us, it's been really helpful. My wife has 48 kits ready to go out to local hospitals in the community, and they're for siblings, they're therapeutic. My 5-year-old daughter was initially, like kids internalize things, she was fine at first, and then 7 months later we realized we did things completely wrong. And the amazing support and outreach and networks we've made with people who stuffed animals, artwork to help for these kids to release these emotions and deal with this. And with packaging that all together with these kits that can be stored, and we're going to give 6 of them to each of the locations that my wife has written down. And we're going to continue. We want to get these eventually throughout the whole state and throughout the whole country. But this is my wife's idea that she's championed, and I'm doing my best to support her with it. And we thank you so much. If anyone has any questions, I can answer some.
Great, thank you. And I would just say, on behalf of the steering committee, we thought it was a pretty compelling application, and we were happy to fund it. Personally, you know, my family's been touched by birth loss as well, and my niece and her wife, one of the ways they got through it was to try to help other people who also were affected by it. So I know how important it is to do that, to have those resources, and the unique part of what you're what you're doing and using the funds for is to help siblings, which sometimes, as we know, unfortunately, in these situations, the siblings can be suffering too and not be acknowledged. So we really appreciate that. We look forward to hearing once the grant is implemented. We look forward to having you and your wife come back and tell us more about it. So thank you.
Great. Thank you.
Just one other announcement in the chat from Katie. I don't know if Katie's still on. Katie Mappa from the Family Center. And this, Kim sent this out. Family Center has a class coming up, Addiction in My Family. It's a virtual class taught over 2 sessions. Wednesday, September 23rd and 30th from 5:30 to 7. So Katie has her email in the chat. And Katie, do you want to say anything about that, or it's pretty much all in the email?
Yep, that's pretty much it. Thanks, Mike. We
Okay.
planning to run a few of these throughout the year. This is the first one, but we're excited about it.
And Heather, you mentioned before about resources. You know, normally when we're all together, not only do we have our coffee and our muffins, but we have a resource table to share programs, flyers, announcements, promote events. And as always, please do get those to Kim, chna23@gmail.com. And that is the best way to send an event or promotion, and Kim will share that with everyone on the list. So someone's asking how to get in touch with Matthew's Gift. Mark, I don't know if you're able to put that email or contact info in the chat. All right, there it is. MatthewsGiftInc.org is the website. And maybe we can send that around too as a link as an email too. So, all right. Well, thank you all so much. I will look at that, 10:15, right on time. Our next meeting will be October 14th, which is also a Wednesday morning, and we fully expect it to be by Zoom at this point. I think for the foreseeable future, we'll be playing Hollywood Squares with each other, which is always fun. Right now, Siobhan, you're Paul Lynn, so if you want to make a snarky remark, this would be the time to do it. Kim does not know who Paul Lynn is, so I'm not even going to go into it. She's too young for that. But we are excited. Donna White, who spoke to us a few years ago about trauma, is going to come back and talk about parents and school-age children and how to deal with trauma. As we're, and specifically on the COVID issue, but in general, she's a great speaker, so we're really looking forward to that. So that'll be October 14th. Again, if you have any announcements, events to promote, please do send them to Kim. And I thank you all for being here, and I hope you all have a great week. Thank you all.